very difficult kind of tumor for most oncologists. This is a very important paper. Thank you.
Well, thank you very much. Unfortunately, I'm not from Amsterdam. It's
You're
a
not.
beautiful city, but I live in Phoenix, so it's very, very hot.
I'm sorry.
So
It said Amsterdam. I'm sorry.
that's all right.
I apologize.
I wouldn't mind.
I apologize.
I think hopefully this will be something less controversial than the previous presentation. So how do I move this to the next slide? This way? Okay. So in the last decade or so, we have really witnessed an enormous improvement in our understanding of pathophysiology of cancer. And that has consequently led to the advancement of the targeted therapeutics and companion diagnostics that have provided some sort of a paradigm shift in the treatment of solid tumors. We have now absolutely sure that just finding a tissue of origin or histologic subtype is truly insufficient to guide the therapy. And there is a definite need for the genetic alteration evaluations that could then prove useful in targeted therapies for these patients with solid tumors. We took that from the publication recently in JCO, specifically looking at the cancers of unknown primary, and have applied that to our database, which includes more than 50,000 patients profiled of their solid cancers from global geographic distribution. Among these 50,000 patients, we identified about 1,400 cancers of unknown primary, giving about 3% of the total cancer burden. And we performed molecular profiling that was aimed at detection of the biomarkers predictive of response, not predictive of the site of the origin, specifically biomarkers of the response prediction. We use multi-platform testing approach, sequencing, immunohistochemistry, FISH and SISH, and matched those results of biomarkers with clinical evidence published in literature that matches those biomarkers to available drugs. An example of a report that we provide to those patients is on the right-hand side. So here's what we found. Slightly bigger incidence in women, which is unusual. Generally, it's considered that the CUP is more often seen in men. And age distribution from 2 years of age up to 92 years of age. However, the average age is 61, which is expected, and just a handful of patients were younger than 20 years. And here's one example of a case, which was a 37-year-old woman who had cancer on unknown primary with extensive bone disease on the left side. And she was profiled in our institute and has been found to carry an activating mutation in EGFR. In that particular example, mutation was found, and the patient, based on that finding, was put on erlotinib. And as you can see, 4 months into the therapy, she had a remarkable, near complete response that was based on the application of a drug that would usually not be considered in a cancers of unknown primary. When we took all of our cases together, we were quite pleasantly surprised that we were able to identify biomarkers predictive of response in 80% of the cases. Only about 18% of cancers after the extensive profiling still remain without any identifiable target. And what was more important in that study is that we were able to find both conventional chemotherapy targets as well as the biological targets, providing an option for drugs that may not be as expensive as one may think. And secondly, these targeted therapeutics are usually not those that you would consider in therapy of CUP. They are really mechanistically associated from other solid tumors. But because this is an unknown primary, we believe that that's a solid basis to recommend those drugs. In conclusion, we can now say that profiling of cancers of unknown primary can provide actionable targets in about 80% of cases. These therapeutic agents that are based on predictive biomarker expression include many drugs that are not considered or recommended by, for instance, NCCN for treatment of CUPs. And in rare incidences, we found mutations that are sort of specific for the site, a primary tumor site, that could further improve management of these cases. Thank you.
Thank you very much. I extremely apologize for not saying that you were from Arizona. I'm really sorry. Can I open the floor to questions? We have no questions. Yes.
Alice Goodman with the ASCO Post. This sort of fits in with where the field is going in a way, because what you're doing is looking at the biomarkers rather than the disease state itself, which we've heard many talks about personalized medicine and how that may be the wave of the future.
Correct.
Right.
We took that approach exactly as you said it. Past attempts to work on a cancer of unknown primary were based on defining a diagnosis and giving odds of a primary site. And yet still you are left without an actionable target. So I basically think that skipping that altogether may be a good idea and going straight for the identification of the pathway that is directly druggable.
I think that this is an extremely important study. I mean, in the past, about 10% of our patients at least have unknown primaries, and it's very, very difficult to discuss with these patients and to tell their families that we have no idea where your tumor is coming from, so we're going to treat you with some chemotherapy that might work for everything. It's very difficult to treat patients like that, to have them understand. It's difficult that they respond to those treatments. I think this really is the wave of the future. And it's an extremely, extremely important paper, which is one of the reasons we chose it as an important presidential paper. We have a question?
Gabriel Miller, Clinical Oncology News. If these are non-traditional approaches that a community physician wouldn't normally think to use, how do you suggest that this might be incorporated into daily practice? If you were a doctor in a rural Arizona, how would you tell them to incorporate this kind of information into the CUP patients that they see? Should they just basically be throwing tests at the patient to try to figure out whatever pathway might be the most effective?
Yeah, I think that one has to be a little bit more careful in saying it that way, because identifying a metastasis without knowing where the primary cancer is in the beginning still should need to try to identify the primary site. And so it's not just like any cancer you would do it and just slap it on. You still have to do some diligence in doing it in a clinical way to find perhaps the primary, and then you are left with a good result in the good percentage of cases. It's either going to find it clinically or you're going to find with another simple pathologic examination where you should look for the primary site. But when you're left without it, when you're really left with a true cancer or unknown primary, then we believe that it's much better to exactly what we were saying here, to look for the identifiable targets. After all, these are all solid tumors. You can also have to take in account it's a tumor milieu. It's not just looking for one marker, because sometimes that one marker may be actually not be working because the other biomarker is expressed. A typical example would be a BRAF mutation with EGFR activation. That doesn't work, so you have to look for more than one. So profiling of a cancer unknown primary is really necessary. Just don't go for one. First of all, your chances of finding that one is a needle in a haystack. But if you have a profile, a reasonably crafted profile that addresses only potentially druggable targets and their interactions, would be the way to go.
But this is the largest group of patients with unknown primaries ever to be studied and characterized. There's over 1,300 patients in this study. And this is what we're hearing is that these patients first have had this gastroscopy, colonoscopy, they've had mammography, they've had all these tests.
Right.
It's like saying a patient is crazy without looking to see if they really have a disease. We're not doing that. These patients have had an adequate medical workup, and in some 10% of patients, you just do not find the original primary.
That's correct. It took us some really time to go through all of the histories that we had, so it wasn't just blindly taken of that, to realize that there was an extensive workup being done on them, and they are still left with no primary site. Or you have a laundry list of potential primary sites. Really, I mean, if you look at that, if you do all of the profiling and you start, well, maybe let's say 70% ovary, 60% colon, 50% chance of being pancreatic. Well, it's all over the place. So what you want to go there is really go straight for the jugular, if you like, and find out what is the pathogenic mechanism underlying and driving this cancer. And that gives you the chance of hit it right in where it needs.
This must be a great relief to the patients who are very anxious because they don't know where the primary site is, and you tell them and their family, but we've studied your tumor, and we're going to try to give you a treatment that is for your tumor. Have you found that or noticed that, or are we at that level yet?
We are not at that level yet to say that confidently for all of them. With the examples that I show are really just the examples. We are the referral lab, so we get those, and it's rather difficult for us to go and chase the outcomes. But one would expect that that's really a helpful additional information.
Will really help patients. This is something that will really help patients in the future. Do we have, yes?
Yeah, I had a question on the outcome. So you said you found an actionable target for 80% of the patients. So how many people you treat, and could you say a little bit about the results?
Yeah.
Is it efficient?
Unfortunately, I'm not the oncologist. I'm a pathologist, and I'm presenting data from the referral laboratory. So we encourage our users, oncologists, to register with us and send us the feedback data. So we are collecting that. Unfortunately, we started it only about 6 months ago. So we don't know. I would not. What I'm showing today is an illustrative case, not really a statistical evaluation of the whole cohort.
There's actionable targets in about 80%, perhaps, meaning that perhaps we don't have the drugs yet for these targets.
As a matter of fact, if you look at those targets and how they are identified, most of them are actually targets for the well-established old-fashioned chemotherapeutics, the topoisomerases, the thymidylate synthases, and so on. So where they actually in established protocols in a solid tumor work. And so they were rarely thought of in the context of a cancer of unknown primary. Now, the more expensive drugs and the more interesting targets, the EGFR mutations, the BRAF mutations, they certainly do appear. But if you're looking at just for those, it's only a sliver of those cancers that we found would have only such targets identified. Most of them have targets of the conventional chemotherapy.
So the personalized medicine can be chemotherapy, and in the past we've given general chemotherapy to everyone, practically the same chemotherapy to everyone, which is not personalized medicine. So we're personalizing even the chemotherapy. I think that's an important message for the readers. You have a question back here?
Yes, Pedro, from Belgian Oncology News. Have you an idea of the cost of this test, and have you to repeat the test?
I have a very general idea of the cost. Again, I run the lab, not the sales of that. And it's been rather well reimbursed in the United States by the insurance companies. Do we have to repeat the test? We try to make our quality control as much as possible, and I can tell you that we do repeat when there is a chance to repeat it within. So it still stays under the same number and the same cost. But what would be more interesting perhaps for you to know is our failure rate, so how often we can do anything. And I would say here, we had, in general, not just on cups, we had about 3% failure rate. The main reason for that failure is that the biopsies are getting smaller and smaller, and they get in our hands after they've been tested for a large number of tests trying to attempt either diagnosis or refine the diagnosis. So most of the time, the failure of the test is actually due to the lack of material to test.
I think that as we use these molecular tests more and more in the future, the costs will go down. But we must also consider the cost of giving chemotherapy that doesn't work to people, the cost to the hospital, the cost to their family, the pain that's involved in that. And so I think that as these tests are used more and more frequently, the costs will go down worldwide.
We have certainly seen the decrease in cost with the advancement of technology. We can now multiplex a lot of text just on one sample, and the cost has gone down.
Are there any other questions? If not, I'd like to thank both of our speakers and thank all of you for your questions.
Thank you.
Have a nice day. Thank you.
Thanks. Zoran Gatalica.
So sorry.
No,